a spine consultant surgeon in King Saud Medical City.
Thank you. Good morning, everyone. So the topic that I'm going to talk about is an area of controversy where there is no class 1 or class 2 or class 3 evidence. I'm going to go through an evidence-based related to this topic. It's a delayed subaxial facet dislocation. And this injury is considered in the literature as old when it passes a 3 weeks period. And it has a very rare occurrence, more in developing countries. And the most incriminated reason in the literature is the insufficient primary assessment, where people do nothing or do just an X-ray and discharge the patient. So the outlines for this presentation, we will talk about how high is the risk in epidemiology and how to avoid such a problem, and if preoperative skull traction is useful in delayed cases, and what is the best surgical approach to follow. Now, the risk in the literature, and this study was found to be 8.2%. This is an old study in '91, and it makes sense maybe before setting the guidelines for when to clear the cervical spine. And it was found in 5 of 61 patients, and the range of delay was from 2 to 21 days. And the reason in all of the cases was the incomplete radiology despite multiple views in one patient. In another study, they found 40 out of 323 patients missed their diagnosis of the musculoskeletal system, and the cervical spine ranked the highest among all, especially the cervico-thoracic junction, with an average delay within the first 2 weeks. So the causes in this study were listed as inadequate X-rays or non-consistently continued diagnostic steps, or inaccurate or not repeated the clinical examination, or the apparent insignificance in multi-trauma patients. In another study, this is a 20-year retrospective study, they found a diagnostic failure of 4.9, and they recommended CT and MRI before clearing the patient. So to avoid the risk, always stick to the basics. You have the guidelines. This is from the neurosurgery, telling when to clear the cervical spine. My suggestion is the only patient who you will send home without doing anything is someone who presented with a trauma, who does not have symptoms, no neck pain, nothing. Otherwise, if you have the facility, do a CT scan for these patients, especially if you suspect a cervicothoracic area injury. So if we see something like this, we have a thought process in our minds. We ask about the diagnosis, if we need further images to reduce or not, do we need an MRI, and what is the best approach, and what are the open reduction techniques. Now, in the acute settings, you can follow the recommended scheme of management. Like in a awake patient, most of the cases, you start with a closed reduction, while if you have an obtunded patient, closed reduction is not recommended as the first-line therapy, and you start with an MRI or just take the patient immediately for an ACDF or anterior approach. Now, delayed fracture is different, and the reason is the more you wait, there is a fusion happening in that segment, so it makes things more challenging and difficult. So the question if preoperative skull traction is useful in a delayed case. Now, in the literature, it was found very much lower than the acute cases. Now, in acute cases, you have a success rate of 90%. This goes down to even lower than this. Like in this study, in 10 of 14 patients with unilateral dislocation, and only 1 out of 5 patients with bilateral dislocation were successfully reduced with a mean duration of 2 days. And the patient presented with the cervical dislocation between 7 and 21 days. So this is not a year or 2 years. This is happening over days or weeks. In another study, they reported a success rate of a closed reduction for 20%, and this is far lower than the 90% or over in acute cases. In this study, they reported the reduction of the dislocation over a 1-week traction in only 2 out of 12 patients. So close reduction is safe, but if you do it, you should always think that the success rate is not as great as a patient who presented in acute fashion. Now, in this study, they found nothing, no benefit at all when they did the close reduction in their 6 patients over a week or 2 weeks of traction, and the delay was around 3 weeks plus minus. So regarding the best surgical approach and what is the best sequence, the literature is merely based on case reports and a small case series. There are not a class 1 or class 2 evidence related to delayed subaxial facet dislocation. And if we go in the literature talking about facet dislocation, both approaches are comparable, and there is no significant or statistical significance between the two. They are both safe and useful, and you can use the one that you're more comfortable with, or both. So the sequence of events or management happening in delayed subaxial facet, there are reports of studies doing traction first before doing anything. So like in this study, this is a 12-case series with 1 to 12 months after the accident. And their protocol started with a 1-week traction, 6 to 12 kg before the operation. And the dislocation was uni in 2 and bilateral in 10 patients. And they found only 2 patients reduced by traction. And these patients were taken for an ACDF and were fused. So the other patients underwent a posterior partial facetectomy. This is when the reduction failed. And if this allowed reduction, they just fixed the patient from the back. And if reduction was not achieved, the traction was carried for another 1 week, and then this is followed by an ACDF. The problem with this approach is that taking the patient from the OR for traction for another 1 week, but the sequence of events can be summarized into traction. If successful, then an ACDF. If not, then you take the patient for posterior and do a facetectomy, and if you reduce it from the back, then fix from the back. In another study, this is a 15-patient series, a close reduction with patients being awake. In patients who had achieved close reduction, they did also an ACDF. In those patients who failed, they carried a combined approach. They advocated the posterior. This study, they did a posterior, and then they flipped the patient and did the anterior approach. So you will find in most of the studies that I'm presenting, most of people with a delayed subaxial facet dislocation, they usually do a combined approach. It's not like the acute facet dislocation. And this is because you need to sometimes take the bone effusion from one approach and flip the patient, fix from the back, reduce, and then flip the patient again. This is a study where they advocated or the same study, they advocated the posterior-anterior-posterior approach for delayed presentation for bilateral facets. And only if they had a disc herniation, they will go anterior first. In another study of 6-patient series, they have the same attitude. They did a skeletal traction for 3 weeks. When the traction was successful, they did also an ACDF. When it's not feasible, they did this under GA. If the reduction is successful, they did an ACDF. If the reduction could not be achieved, they underwent a posterior facetectomy as well. And once the reduction is achieved, they will fix from the back. And they usually do 2 levels above and below in most of the patients, unless the patient is young or planned for an ACDF. So other series, they do an anterior first without doing a reduction. Like in this study, this is a 17-case study of delayed dislocations, and they did an anterior discectomy first while the patient is supine and intubated to remove the fusion mass and to achieve the discectomy, and they filled the space with a graft. Then in a second stage, they flip the patient and do a posterior stage where the dislocation was reduced and the lateral masses were fixed. In 8 out of 17 patients, they found bone effusion at the facets where this has to be removed. Another study, a series of 3 patients, more than 8 weeks delay. They attempted the classic anterior, posterior, anterior, but they failed to reduce the dislocation the first anterior stage. So they added another posterior, so they ended up with AP. And this was later abandoned in their cases. So they did the anterior stage to remove the fibrocartilaginous tissue, posterior stage for screw placement, and then anterior stage for reduction and fusion, and eventually posterior for rod placement and posterior fusion. This is not commonly done. I only found it in this study, and the author themselves, they abandoned in the last patients. So after the failure of the first 2 cases, they decided to carry out just a posterior release first, and then anterior reduction and fusion, followed by a posterior. So they ended up in a PAP. In a series including 13 patients, they recommended an APA method as well. This is a study done in Japan. Other series, they did posterior first. So after intubation, they flipped the patient, doing nothing anterior first. Like this study, they did in 9 patients, either the PA, posterior release, and then anterior release and reduction, and or the PAP, where they do the same, but with last step with instrumentation. This is another study for 4 patient series, the same sequence, posterior release and facetectomy, and they did wiring, and lastly, they do an anterior approach. So, in conclusion, this misdiagnosis of 3 weeks and more is very rare nowadays. Still, it's a problem in the developing countries. Advice is stick to the basics. Do not clear the patient unless you follow the steps, and they are easy to follow. They are found everywhere. And closed reduction can be an option with a high failure. I personally like to do closed reduction first, because if you have the setup to do it, it's a good option. It's very safe, especially in awake patients. And combined approaches are usually needed, because if you go one approach, you will find fusion masses that you have to take out, and you flip the patient. So always expect doing a combined approach. Unless you did a closed reduction and this patient reduced well, then maybe anterior approach is enough, especially if the patient does not have a posterior ligamentous injury. And as I said, there is no class 1 evidence to support the best approach. So it's your call. Follow your gut feeling and a bit of common sense. And thank you so much.